pediatric nerve disease is different than adult disease because there isn't very much of the toxic neuropathies like there is in adults, diabetes being the biggest one. Even if children have diabetes, they don't have it long enough to develop a neuropathy typically. So most of the neuropathies in children are, the most common would be an inflammatory neuropathy like Guillain-Barré, post-infectious inflammatory. And then there are an increasing number of recognized hereditary neuropathies that can be identified in children. So if a patient presents, if a child presents with an atypical type of neuropathy, a nerve biopsy can be very useful in identifying the substrate, the nature of the underlying disease, and guide the approach to genetic testing and further diagnostic testing. It saves a lot of time. It can save a lot of money. If you do the hereditary genetic studies for neuropathy, it can cost many thousands of dollars. If you have a focused direction you go, you can make the diagnosis in most kids for relatively inexpensively. So that's the chief role of biopsy is for atypically presenting children with using it as part of the systematic evaluation of the neuropathy so that you have a direction to go for your more expensive diagnostic tests. Children with neuropathy, the most common forms are inflammatory, and that would include Guillain-Barré, but it would also include the chronic inflammatory polyneuropathies, which usually start out like a Guillain-Barré but then have a relapsing and remitting course and end up with usually immune modulation therapy over time. We see those in adults as well, but if you have a chronic neuropathy in adults, the differential is expanded some because of the toxic neuropathies, and in children that's less common. And so I think the other large group are the hereditary neuropathies, and as we've learned, when I started in this business, Charcot-Marie-Tooth was one disease. We now have at least 50 different genetic mutations that produce a hereditary peripheral neuropathy. Most of the time it's progressive. And so now Charcot-Marie-Tooth is not Charcot-Marie-Tooth, but a number of other diseases. And to classify them well, it requires a systematic approach, including good quality electrodiagnostic studies, often including a biopsy for atypical cases, and then including focused genetic testing. We're at the cusp of a very exciting time in management of pediatric neurologic disease, in large part because of our increasing skills with molecular diagnosis and genetic diagnosis. The major change in the last 3 or 4 years is the development of the CRISPR technology, which allows us to construct pieces of DNA and opens a whole variety of diseases to the possibility of genetic therapy. The disease-modifying nonsense oligonucleotides, which in spinal muscular atrophy, the new drug was approved just in December, and from the preliminary data, at least, or from the initial data seems to be a disease-changing therapy. It is a similar story in Duchenne dystrophy. There are at least 2 treatments for small segments of Duchenne patients that change the way the RNA is produced and change the outlook for these patients. So the development of new molecular technologies has resulted in the production of some really spectacular new drugs that unfortunately are very expensive. And the challenge is to be able to make these drugs available to everybody. We need to have some sort of a meeting of the minds about that. There will be more of these drugs, fortunately, and they will be very expensive, unfortunately, over the years. So we need to work out access to our patients.